There needs to be a film. There needs to be either a film or a television series about his life. And I'm going to approach a literary agent I know in Toronto, and I'm proposing this idea to him because I think it would make for one hell of a series.
That would be awesome. Of course, now round tripping this entire conversation, maybe you can get Justin Bieber to play Tommy Douglas in his early days or something. Hi, my name's Lester, and welcome to another episode of What's with RWE, the Canadian Healthcare Podcast. So, as many of you know, we have been diving really deep into healthcare to try to understand how we got to our current situation in Canada. And of course, in order to do that, we have to look into the past. And I have scoured the internet to try to find the perfect person for this. And I believe we have. So, welcome, Greg, to the podcast. Thanks a lot for joining us, Greg, on a Sunday of all days as well. So appreciate that.
Oh, Lester, my pleasure to be here.
So I'm going to do a quick introduction for Greg, and then, of course, we'll jump right into the conversation. So Dr. Gregory P. Marchildon is a Professor Emeritus at the University of Toronto. For those of you who don't speak Latin, nor do I, Greg tells me he retired in July of 2022, but he still has an appointment there at University of Toronto, but none of the bureaucratic stuff that he used to have to do. So I assume you very much appreciate that. He was the professor and Ontario Research Chair in Health Policy and System Design at the University of Toronto prior to his retirement. Before that, he was the professor and Canada Research Chair in Public Policy and Economic History at the University of Regina. He also worked for the government or in the government of Saskatchewan. He is, of course, a very prolific author, one of which he actually had you actually co-authored a book with one of our past guests, Dr. Catherine Frielbeck, called The Boundaries of Medicare, Public Healthcare Beyond the Canada Health Act. And of course, the reason why we're having a conversation today is very much because of your most recent book, Tommy Douglas and the Quest for Medicare in Canada. But last but not least, Greg and a couple of his other co-hosts host one of my favorite podcasts now, Witness to Yesterday. I literally found out about it maybe a month ago, and now I am hooked. It is definitely in my top 5 of podcasts I have to listen to. So thank you again, Greg, for being on the podcast.
Thank you for inviting me.
So let's just jump right into Tommy Douglas, and let's keep things incredibly light in the beginning. And I would say, actually, the entire conversation is going to be light. But one thing that I have to get your opinion on. So in 2004, this is 20 years ago, right?
Yeah.
Tommy Douglas was voted on CBC poll as the greatest Canadian, right?
Yes.
If you now fast forward 20 years today, with the additional 20 years, Greg, do you still believe Tommy Douglas is the greatest Canadian? Would you give him your top vote, or who else would you have put in that on the top of the list?
Well, I would give him the top vote. I wouldn't have devoted so many years of my life researching and trying to understand him if I didn't think he was one of, if not the greatest Canadian. I'm not sure, though, that he would win the poll today, only because I know so many people in their 20s and 30s who have never heard of him. And it surprises me because just about everybody over the age of 40 and 50 for sure know and remember him. But the memory is becoming a little dim with time. And I'm hoping that the book will, in a sense, bring him back to life for a new generation of Canadians that just are not familiar with him.
I completely understand, and I guess you wouldn't put Justin Bieber on the top of the list, as many people may do.
Well, the interesting thing is Tommy Douglas beat out prime ministers. There were a few prime ministers on the list, as well as sports stars. Hockey players are always a favorite among Canadians, and celebrities and heroes, people like Terry Fox. And I'm not saying he should have, but I am saying it's significant that at that time in Canada's life, if you like, that Tommy Douglas managed to come out on top. And it wasn't just Tommy Douglas, it was the idea of Medicare. And you can't separate the two. When you say Tommy Douglas, you basically say Medicare in the next breath. And it's as much a vote for the system of Medicare that we developed in terms of its principles, less about the way it's actually delivered, as we'll talk about later on. Uh, but the principles that Canadians are very much, I think, they believe in and feel are the right ones. And I can get into depth on that, but it's the style of Medicare that he introduced in terms of that single tier and a single payer system, and the idea that everyone should have access on the same terms and conditions, uh, irrespective of their ability to pay, but based solely on medical need. And that principle is important to Canadians, not just because they get something out of it for themselves or for their families, but because they want their neighbors, their friends, as well as Canadians they don't know to be protected by the system. And I think this is an aspect of Medicare that we don't pay enough attention to, is the comfort that comes with the idea that you know that all your fellow citizens are also protected.
Absolutely, absolutely. Just a little joking aside, there we don't want the Justin Bieber fans to just jump all upon us. So we have no problem with Justin Bieber. I'm pretty sure Greg is not saying he's a problem with Justin Bieber as well. But yes, going back to Tommy Douglas. So Greg already started a conversation here. For those of you who do not know who Tommy Douglas is, many people would consider him the individual. I know you would say that there are quite, and he probably would say that there are quite a few other individuals that help usher in Medicare
Exactly.
into Canada. However, a lot of people think of Tommy Douglas as the almost like the primary individual, that person that led the charge, let's say, for Medicare in Canada. So maybe back to the point that you made, that this principle that he had at least ushered in and infused into at least the Canadian Canada's form of Medicare, this idea of just people shouldn't have to pay and it should be equal across the board across Canada. What did that stem from? So maybe you can speak to a little bit about Tommy Douglas's kind of early, like what influenced him to have that type of mindset and that type of mentality to develop that type of Medicare.
Well, yes, and this is a really important question, Lester. Before I answer it, I'm just going to go back to the idea of Tommy Douglas's role in Medicare very quickly to emphasize the fact that there were a lot of other people involved, but there was no one more involved at the very front end of Medicare. He developed the first program of universal hospital coverage right after the Second World War in Saskatchewan that became the model for the rest of Canada. And the rest of Medicare, including its extension to medical care or physician services, was based upon that model. Second of all, he was the only individual that was involved from the 1940s right up until he died in the 1980s. Others were involved, but only for specific periods. He was involved throughout the evolution of Medicare in Canada, which was a 50-year evolution. It wasn't an overnight thing. And so that's why I pick him out as the central figure in this. So now let me go back to your question of why did he decide that we needed this in the form that he developed it, a single payer and single tier. There's two, I think, principal reasons for that. The first is his dedication to something called the social gospel. He was a religious man. He trained as a minister in the 1920s and became a Baptist minister by 1930. He was heavily attracted to an idea that was then circulating about what I would call the teachings of Jesus and the idea that the kingdom of heaven should be on this earth here and now, and that what you do here is what counts in life. And how you help people, how you ensure that there's a better life for future generations, that's what counts, not waiting for the life hereafter. The Baptist church, like many of the Protestant churches of the time, were divided between a so-called progressive wing that adopted these attitudes and I would say more conservative wings of the church that basically said that you shouldn't get involved in such issues as dealing with public policy and what's right and what's wrong here on this earth, because that's getting yourself into politics. And politics should be a different realm, and that's not a realm for the religious. Douglas disagreed with that completely and felt that it was very important that he needed to take a stand on these issues. The second, though, was the Great Depression itself, which began in 1929 with the stock market collapse. And it hit particularly hard in the area that he was working as a minister in southern Saskatchewan, in a little place called Weyburn. And he could see the human devastation that the Great Depression and years of prolonged drought uh, caused to the people that he ministered to. He could see the damage that was being done to farm families, to small businesses in Weyburn. He could see the damage that was being done to the hospital that could barely keep its doors open because there were no longer people were no longer able to pay to get care, to doctors who were no longer able to have people pay their bills, and then to people who avoided going to see doctors and going to hospitals because they couldn't afford to pay. And so he just felt that that was wrong, that access should not be based on ability to pay, but based on medical need, that in fact, access to high quality health care should be a social service rather than a commodity to be bought and sold in the marketplace. And so he came through the Great Depression believing in this quite fervently and talked about it quite extensively during the 1930s after he joined a new political party that emerged in the prairies called the Cooperative Commonwealth Federation, a real mouthful. Everybody calls it the CCF, but it was a so-called socialist or social democratic party that was dedicated to reform. And like the more right-wing variant of social credit that emerged in Alberta about the same time, basically arguing that the two establishment parties, the Liberals and the Conservatives, were just not doing enough for people during this horrible depression, and that they should be trying to help people through public policy, through programs, through public works that would hire people and not just sitting on their hands. And so the party that he joined um, fervently believed in what they then called socialized medicine. But really, what they were talking about most of the time was universal health coverage. And they wanted it to be comprehensive. Now, Douglas uh, did not succeed in his first attempt in politics. He ran in a provincial election in Saskatchewan in 1934. He didn't do very well, but he learned a lot of lessons. And then when he ran for a federal seat in 1935, he was successful and became a member of parliament. That's when he quit being a Baptist minister. He no longer had the time for that. And he spent years in Ottawa, but he came back to Saskatchewan to become the provincial leader of the CCF, thinking that this would be the place where the CCF could actually win government and begin to do things rather than simply criticizing the governments in power for not doing enough. So that's why he came back in 1942, became leader, and prepared the party and the MLAs for election, and they won a massive victory in 1944. And the platform was very clear. They would introduce a system of comprehensive health coverage. That's what he intended to do. And at the time, he thought the federal government would help out. And now I'm getting far beyond the story that you want me to tell right now, but that's when it all began.
Great, great. So it's very kind of interesting that you point out that I mean Tommy Douglas actually lost his first election. That this was he it wasn't something that he just you know it was a sure thing, and he won throughout the entire way. Because I listened to some of his speeches more recently, and I tried to recount them to my wife because they're so good. I mean, of course, the one that's the one more famous ones is that very funny story he tells about mice and cats, right? So I'm going to link it to the in the show notes so people can listen to it. But it's very kind of interesting that it take him time to kind of hone his abilities to be able to win that seat, and of course become premier of Saskatchewan. Or was that was it just the right time for him, or was it he always had the capability? It was just wasn't the right time, or did he actually have to improve himself in a way that made people want to vote for him?
He certainly had to improve his ability to speak to the public. At first, he himself admitted he would talk about policy, but he would talk about policy like he was some professor. He was a well-educated man. Got his master's degree. He was working on a doctorate at the University of Chicago in sociology. Uh, and he talked about policy in very complicated terms in 1934, and he just could not, in a sense, get much traction with the general public. And he realized two things: one, it was important to use humor to get people to, in a sense, listen to you in the first place, to get their attention. And second of all, he had to put public policy in the very terms that people would understand it. So he had to speak a language that everyone could understand. And it took time to hone that ability. He wasn't dumbing down his speeches, but he was speaking in terms, very concrete terms that people would understand. And I note that, you use the idea of real world evidence here. Well, he needed to use their real world evidence to begin to describe these things in ways that would make sense to them. And he became very practiced in that ability over time, but he did not have it naturally. So it took some time. Now, the other thing about it wasn't just, and in fact, there was very little to do with the context of the time, because the CCF did very poorly in the 1935 election, actually. There were only two members that were elected in Saskatchewan. It was a tiny caucus in Ottawa. It was a minuscule third party. So it wasn't like there was any momentum at the time in favor of the CCF. In some ways, I'm sure he felt like the party and what they had to say in Parliament was like a cry in the wilderness at times, and that they had to do all kinds of things to become noticed. And that made him very good at dealing with the media. Uh, it made him very good at radio speeches, so he could, in fact, go over the heads of the media to talk to the Canadian public directly. These are all skills that he practiced with time. He had some advantages. He had been trained as an actor when he was younger, growing up in Winnipeg. And so he used some of his skills as an actor, uh, a dramatist, if you like, to add to his speeches when necessary. He knew the tricks of the trade, but still, um, to translate that into an effective political orator took some effort.
That's great to know, because sometimes or at least for myself, maybe in some ways it's not accurate. I always Sometimes you feel, oh, that person's blessed with it, right? Quote unquote blessed, it's genetically, whatever it may be. But it's nice to hear that someone really worked hard on something. It took them a long time, and then finally he was able to succeed. So maybe on one thing that I incorrectly assumed when throughout my entire life until more recently when I worked within healthcare is I just assumed like, oh, public healthcare just makes sense. Everyone seems to have it, right? The UK, France, so forth, right? First thing, I didn't understand that it's actually quite nuanced. Every single country seems to have a different version of single, quote unquote, single payer system. And just assumed it was an inevitability that you just it just makes sense. Public health care, right? The single payer system. But that is not the case. It seems like you had to have people like Tommy Douglas and his band of colleagues that really not just pursued it, but also how to implement it as well. So maybe you can speak a little bit about some of the challenges that they went through. It's such an incredible story that I just assumed it was, oh, it's super easy. Everyone, it seemed like a very clear thing, but that is not the case at all until I learned it very recently.
Yeah, in fact, universal health coverage is a relatively new thing. There are a number of countries that had some form of social health insurance for those folks who were employed in factories, etc., in Europe from an early period, but that was not universal health coverage. That kind of coverage only applied to them, and in part because they paid into a system that their employers contributed to. The government provided legislation that basically ensured that it was mandatory. But if you weren't working in a factory, you were self-employed, or you had part-time employment, seasonal employment, or you were an agricultural laborer, you wouldn't be covered by that system. So it wasn't really until the Second World War and after that ideas of universal health coverage started emerging. And even then, there were countries in which they never really did move to universal health coverage. Instead, they subsidized um, access for certain groups of people, but not for the entire population. And that's what we mean by universal health coverage, right? And in fact, Saskatchewan was at the very forefront of introducing universal health coverage. The only other country that had attempted, jurisdiction that had attempted to do it in the late 30s and early 1940s was New Zealand. And there were problems with its implementation, and they still had user fees. Doctors still charged extra billed, we call it. And so it wasn't the kind of free access that Tommy Douglas wanted in Saskatchewan, and he ensured that the system delivered that. So there wouldn't be any financial barriers to access, whereas the New Zealand system had some. So then it took another 18 months after universal hospital coverage was introduced in Saskatchewan before the United Kingdom implemented the National Health Service. And there was no costs associated with access to hospital care, doctor care. Um, and it was intended to be a system, so they took over all of the hospitals. Douglas did not do that in Saskatchewan. The hospitals are still being run either by municipalities or by the Catholic Church or by other organizations. Uh, and instead, he paid for patient care, and they received most of their money through payments directly from the government to cover off patients, and they could no longer charge patients for that care. So that's what we mean by single payer. It was really, in my view, the first jurisdiction wide single payer system in the world. Followed by, of course, the National Health Service, which was designed differently, and then universal health coverage in other countries slowly began to emerge, but there was always a fight because there were always groups that were dead set against it. Generally, uh, corporations would have a lobby against it. Doctors almost invariably through their medical associations in whatever country were against it. Some of them fought. They actually went out to a full strike against in trying to prevent universal health coverage from being introduced. I did an article with a friend of mine from Belgium because we were comparing the doctor's strike of in Saskatchewan in 1962 to the general doctor's strike in Belgium in 1964. But it was exactly the same issues that were involved. So it was very, very difficult to introduce universal health coverage. And you could do it in stages. So hospital coverage came into Canada by the late 1950s, early 1960s, based on the Saskatchewan model. And there wasn't a lot of opposition to that. There was some, but not a lot. But when it was extended to physician coverage, then the opposition really kicked in. And it became a struggle, not only in Saskatchewan, but in other parts of the country as well.
And that's so interesting because until I heard this the history of how Tommy Douglas and the rest of his team was able to usher in coverage from a primary care perspective, I did not understand that doctors were so against it, at least in the beginning. Right now, most you we actually recently had Dr. Josh Reimer on the podcast. She's the president of the Canadian Medical Association, and
Yep.
of course, nowadays everyone's super for it, right? It's like, oh, us compared to US, look how terrible their system is compared to us. Like that's simplifying it a little bit here, right? But it seems like everyone is so behind it. But there was a strike that actually happened that doctors didn't actually want that to happen. So what essentially forced it, or not, maybe not forced is not the right. What convinced the doctors to go, hey, you know what? Maybe we should give this a try, and this is perhaps the right way to go.
Well, I don't think it was about convincing them at the time. And I should make a distinction between doctors and organized medicine here. Uh, these are the organizations that speak for doctors that, in a sense, represent them politically, from the Canadian Medical Association to all of the provincial medical associations, and the leadership in those bodies. And it was organized medicine that was dead set against it. Of course, there were doctors, some of them working in rural and remote areas and other places who were more sympathetic to the idea, but they were definitely a minority. The majority of doctors supported their medical associations in their positions. They elected them, after all, to those positions, and were dead set against the idea. And it took time after Medicare was introduced, first in Saskatchewan, then in other provinces, for it to be accepted. But keep in mind that, there was not only a doctor strike in Saskatchewan in 1962, there was also a strike by medical specialists in Quebec in 1970 when Medicare was introduced there. And when the provisions against extra billing were introduced by the Ontario government in response to the Canada Health Act in that period shortly after 1984, doctors went on strike in Ontario as well. So there's a history of this opposition to Medicare and certain dimensions of Medicare from the very beginning. And the medical associations, especially the Canadian Medical Association plus other provincial medical associations, were dead set against the single payer design and instead argued in favor of a multi-payer system in which individuals who could prove they could not afford to buy private health insurance would get a subsidy from their governments to be able to purchase private health insurance. That was their preferred system for many years. And they were very, I mean, these associations were very upset that governments chose to adopt Douglas's model of single payer and single tier. Now, what do I mean by single tier? Just very quickly to explain what that is, because everybody knows what single payer is. That means the government pays all the bills. There's no insurance companies involved. But single tier is a bit of a harder concept because we've never known any other system in Canada. So we just take it for granted. But in most countries, there are two parallel systems. There's a public system of hospitals and doctors, and there's a private system of hospitals and doctors. You can purchase private health insurance or through your employer get private health insurance, and you have exclusive access to the private system. If you don't have that insurance, however, you have to go through the public system. Invariably, however, the problem is that in these countries, uh, the private system uh, probably has fewer wait lists. It is easier to get into, and you don't have to sit in an emergency department waiting room with people that you may consider riffraff. You're with people that can afford to pay or that have really good jobs and have really good insurance. Um, and so you're divided. The population is divided. The facilities are divided. The providers are divided. Canada does not have that system. The vast majority of doctors have Medicare patients. There are a few private doctors. There's nothing preventing doctors from setting up a private practice, but outside of the largest cities, there's very little sort of business case for it. So most doctors basically have Medicare patients. There's no such thing as hospitals that will not admit you on the basis of your Medicare card. Basically, you have access to all hospitals in the country. That makes our system very different than other systems. Even the National Health Service in Britain has a small private tier, right, that's separated from it. Most of the continental European countries have that system. The big exception in Europe are the Nordic countries: Norway, Sweden, Finland, Iceland, Denmark. Those countries also have single tier systems. So Canada and the Nordic countries and a few other countries in the world, we have this, it's a minority position, but we have single tier systems where we don't basically exclude people from a certain private hospital because they don't have private health insurance. The thing about it is that it's not, we don't care whether it's a private or a public hospital. In Ontario, as you know, most hospitals are private, not for profit hospitals, but they have to accept, and they do accept all patients, right?
Got it.
So it's not about the ownership of the delivery system, it's about the rules of Medicare, which means the rules say you have to have access to all the facilities. It's beginning to break down a little bit in some places in Canada. And that's very concerning. And I know Douglas would be rolling over in his grave to know that because he always intended it to be a single tier system.
Okay, actually, let's do that. Let's take Tommy Douglas and let's strap him on to a time machine, and let's actually bring him all the way to the present. And what would if Tommy Douglas was here today and he looked at our healthcare system, what would he be, let's say, surprised by? What would he be a little bit disappointed by? What would he be actually thrilled by? Like, what's your perspective? Conjuring up Tommy Douglas, of course. I mean, of course, we unfortunately do not have a time machine, right? But what would you say, Craig?
Yeah, well, I'm in danger of basically explaining to you what my views are rather than Tommy Douglas's view as I channel him into the present and the future. But I'll try to be as honest as I can about this and think about it from his perspective rather than my perspective. I think it's fair to say he would be extremely disappointed about two things. Number one, he would be awfully disappointed about the fact that there has been no expansion of universal health coverage since the 1960s. Basically, we stopped at physician services. That was never his idea. His idea was the system would be built in phases, that we would eventually achieve comprehensive health coverage. So, the 1950s, universal hospital coverage nationwide. Then the late 1960s, universal medical care coverage nationwide. And then the next step, from his perspective, would have been prescription drugs, then home based care, uh, and then long term, institutional long term care. All of this he wanted put within a comprehensive system. And he just felt it would take time to do, but that we should keep building. He did not see uh, the Canada Health Act, for example, as the end point. For him, it was a disappointment because it didn't go further than what we had already achieved in the 1950s and 60s. He agreed with the idea that at least the Canada Health Act was addressing the problem of user charges and physician extra billing, but he thought it was an opportunity to expand coverage and it wasn't used. So he'd be very disappointed to come to today, 40 years after the Canada Health Act, only to realize we hadn't really taken any further steps. The second thing, and this one he would be shocked by, I think, that we have an access to care crisis in this country. The whole point of universal coverage was to have and ensure access. And there was no uh, question that people receive care on a timely basis. There was no question that everyone could get primary care and get a family doctor when they needed one in his day. And that remained true for years after he died as well. This really only became an issue in the early to mid 1990s that it began to emerge. Today, we have a serious access to care crisis. We have a very large percentage of Canadians with no access to primary care as we know it, which is highly problematic. We also have extreme problems, for example, in emergency departments, people waiting for hours and hours, sometimes with very serious conditions, to get the urgent care that they need. And it goes on and on. We have to wait months to get a specialist. We have to wait a year or two for what may be considered to be non urgent, but is pretty important care or surgical intervention. We have to wait to get a referral to a specialist, sometimes for just an inordinate amount of time. Just think about the wait times for to see a psychiatrist. He would be actually quite shocked at that. And I think he would say, okay, we need to work on this and we need to get this right immediately. He would see this, I think, as a threat to the basic principles of the system as a whole, and that we had better fix it or the whole system would be in danger, and the values that underpin the system.
Do you think there would there be anything that he would be surprised from a positive perspective on that? Wow, I didn't think that would happen, and it did happen.
Well, it's a tough one because I'm trying to think. I think that he would be quite amazed at all of the alternatives uh, to um, surgery, to what I would call major medical intervention, through, for example, certain prescription drug therapies, through the application of cognitive behavior therapy, or through all kinds of things uh, that basically do not require you to have a bed in a hospital, that don't require you to go under the surgeon's knife. And he would be very pleased about that. He would see that those kinds of advances in medical knowledge, technology, and science is very positive. I mean, he could see some of that in his day, but the pace and the extent of what we have now, I think he'd be delighted with. And he would want to see this incorporated because his idea was everyone should have access to the very best that medical science can offer.
Great, great. Actually, just for fun, I asked ChatGPT what to invoke Tommy Douglas and what would ChatGPT think that Tommy Douglas would say. And actually, very very similar to what you talked about. There's two things from a disappointment perspective that ChatGPT brought up, and I actually want to get interesting get your perspective on it. I can kind of see why ChatGPT would say that Tommy Douglas would say this, but okay, I'll say the first one that yeah,
Okay.
that you didn't highlight was persistent health inequities, the one specific around Indigenous people. So that this was something that ChatGPT said that Tommy Douglas would believe that this is a huge disappointment to him, and I think it probably stems from he was actually very very progressive for from a certain perspective. He was incredibly progressive, right ahead of his time. I think Saskatchewan was one of the first places to almost like introduce a Bill of Human Rights. Am I correct about that? So,
Yes.
what do you think that that was something that Tommy Douglas would say? This idea of health inequities would be something that he would be highly disappointed in.
Yes, he would be. The reason I didn't raise it was because it's what he saw in his day. And I know this isn't going to be a popular thing to say, but what he saw in his day were even greater health inequities than what we face today. Remember, he was coming out of the Great Depression, and the gaps at that time were absolutely enormous. And there was virtually no safety net. So, as he lived and experienced as a politician and as a government leader, and then as an opposition politician in Ottawa in the 1960s and 1970s, he saw some of these things being addressed very effectively through government policy. And even if it was opposition parties that he criticized, they built up the welfare state in the way that he'd hoped to. And of course, he wanted to go further. He wanted the safety net to be larger, to be deeper, but they were going in the right direction, right? So I think by the time he died, in 1986, he felt it was still going largely in the right direction. Um, Now, it wouldn't take very much longer before the 1990s came along, and all of a sudden, once again, the gap or the inequities began to grow. Now, I'm talking about the general population as a whole. Let's talk about marginalized populations. Let's talk about Indigenous people. There, he would have made the point that we needed to do more, and he did, in the last 20 years of his life, make this point quite often, that this was something that needed to be addressed and needed to be a priority for Canadians. He did not see, though, this issue through a cultural lens. He saw it through an anti poverty lens. And in that sense, he might be a little different than people today and their arguments about First Nations, self government, etc. Because I think he always saw this as a problem of poverty in education as opposed to a problem of cultural isolation and sort of historic wrongs.
Great, great. Spoken like I think a true historian, whereas I think ChatGPT didn't take that approach. I think on one of your podcasts recently with, or it might not have been actually that recent, with former colleague Patrice Dutil, the way that he verbalized what a historian does versus a journalist is it was quite succinct, and I thought it was quite incredible. He said that historian, they put the individual or the situation into context of that time, and that's what you're doing here. Whereas it seems like ChatGPT just didn't do that. It took a more of a journalistic view on it, maybe.
Well, I think that that's the problem with artificial intelligence, though. It can only be present minded, right? The historical judgment is something that is unique to human beings. I doubt that we could ever use artificial intelligence to mimic that. Maybe I'm wrong because artificial intelligence can do things today that I never thought would be possible. So I could be very wrong. It might be able to have that kind of historical depth at some point. But
Absolutely.
for my sake, I hope not. As a historian, I hope there's still some human agency in all of this.
Absolutely. No, myself as well. I think all of us think, oh, can it replace all the work that we do? And I think I'm on the side of, like, we'll always have a place. I mean, as long as there's creativity, there's problems to solve. I think we'll always have sort of a unique perspective on how to actually solve that problem from a humanities perspective. But actually, before we take Tommy Douglas and maybe now put him again on that time machine and fast forward it to the future in terms of how he would maybe steer the ship in terms of Canada now to the future of Canadian healthcare. Maybe you could dive actually a little bit into your background, Greg. Apologies for not doing this a little bit earlier on, but there's one thing I noticed that you graduated, I believe, from the London School of Economics, did PhD there, specifically around, I think it's called. Sorry, I'm in my notes. Economic history.
Yeah,
What
that's
does
right.
that mean, actually? And of course, you were chair in public policy and economic history at University of Regina. And I don't mean this facetiously, and there's no, what is the perspective? Is it more economics than history, or is it more history than economics? What does that mean? And how did you get to being so obsessed with, let's say, Tommy Douglas?
Well, from the very beginning of my academic career, I I I was interested in both subjects to the point that I had trouble making choices. So I did my undergraduate degree as a double major in history and economics. Uh, and then I did a master's degree in pure economics. And then I started my PhD in pure economics. But I was trying to do economic history, and I had to actually leave Canada and, for that matter, the United States to do that because there weren't any programs. So I went to Britain where there were still programs of economic history. It's sort of divided between the two, but you work as a historian. using archival sources, etc. But you have some basic training in econometric methods, time series analysis, and the tools that economists use. But what you don't accept is that what I would call that I'll be a little facetious here, the over theorizing of economists, the oversimplification at times through that theorizing. You emphasize, in a sense, trying to understand the empirical sort of context. And when you do statistical analysis, you're not imposing a grandiose theory so much as trying to find out what some of the sort of causal factors are to the greatest extent possible, understanding the limitations of these tools. So I was very interested in doing that, and I wasn't sure if I would ever get a job doing that because there's not a lot of demand in either the U.S. and Canada for economic history, and in fact, I found that there was very little demand in Canada for it, but there was a university in the United States, Johns Hopkins University. They had a School of International Relations, and they were really interested in having an economic historian, and they hired me. So that's where I went, and that's where I got my first academic appointment. I was very lucky because I probably would have been forced to go into some department of economics in Canada and teach Econ 100 or macro economics or microeconomics for the rest of my life. And I certainly didn't want to do that. So I was very lucky in getting that first position and given the right to create the courses I wanted for those students. And so to this day, I thank my lucky stars that I was able to pursue what I loved doing, and then I was able to actually make a living doing it. So that was, but the public policy side of it came in later. I was always interested in public policy, but I was 5 years into my sort of teaching and research at Johns Hopkins University when I was asked to have an interview in Saskatchewan to be a deputy minister. And I decided to temporarily give up academic life to be a public servant. Uh, and then I was going to go back to Johns Hopkins University. But what happened was that shortly after working for 2 years as Deputy Minister of Intergovernmental Affairs in Saskatchewan, I was asked to be Cabinet Secretary and Deputy Minister of the Premier and Head of the Public Service. So I had to give up the idea of returning to academic life for quite a few years where I did that job. And then that led me to when I did step down and decide to go back to academic life, it was interrupted again when I was asked to negotiate a mandate for a federal royal commission called the Commission on the Future of Healthcare in Canada. And then I ended up becoming the executive director, and for 2 years worked on a royal commission. It was only after that that I was able to go back to university life. And that's when I was a Canada Research Chair in Saskatchewan.
Great. Actually, on that note, since you spearheaded this commission on sort of the future of healthcare in Canada, now let's layer in maybe if you can. Again, I know I'm asking a lot of you here, and we're up against the time. So, but I'm happy to if you're okay going over, I'm happy to go over as well. Is what do you think Tommy Douglas would do today in terms of trying to improve healthcare for Canadians? Looking at the backdrop, maybe I know there's quite a few challenges, but let's maybe specifically focus on primary care here. The idea that there's so many physicians, it's basically long wait times for primary care physicians. What do you think his approach would be in the current, current situation?
Well, I think he would insist that where there are groups of people not being served, that uh, the government step in directly and ensure that there are the clinics and the personnel available to provide that primary care. That you don't simply wait for the market to fill that vacuum through privately practicing physicians. That you rely on nurse practitioners or registered nurses in community health centers, or that you in fact arrange for those you know groups, community-based organizations, etc., to set up those clinics and be paid through the public purse to provide primary care. I think he would have moved very aggressively on that. He believed very much in what was called the community clinic in Saskatchewan, where doctors came together to work with social workers, nurses, and other health professionals to provide comprehensive primary care. And he himself supported that concept, spoke about it extensively in the 1960s and 1970s. And so he would very much support that kind of development. Um, he would also probably insist that every individual and every family have and be registered to a primary care practice to ensure complete coverage, and that they would be up to the practices to ensure that it would be after hours coverage and on weekends, so that people would not have to go to an emergency department room, or uh, only in cases where they needed extremely serious urgent care, but they would be looked after in terms of these primary care clinics. A lot of the reasons that people are going is because they cannot get care after hours. They can't even get an appointment at their primary care clinic that within a day or two after they call in to say they've got a problem, even during office hours. And those are the issues that he would want to see addressed, I'm sure.
That's incredibly interesting because I think I forgot who I spoke to about this. I think it was actually and another previous guest, Tyler Meredith. If you, I'll put that in the show notes. He was an economic advisor to the current Liberal government in terms of the economic policies and so forth. And he had mentioned that Canada, at least from a healthcare perspective, had moved towards a very hospital centric type of model. So actually, from Tommy Douglas's perspective, despite him ushering in the Hospital Act, when one of his first things that he did, he actually didn't necessarily believe that all care should be delivered in a hospital. He actually more believed in these community clinics where care is actually delivered in the community setting.
Well, community setting and in home. He very much believed in home-based nursing care, what we would today just call home care. Uh, and he would also, have argued that there was a big role for prevention, and that prevention should be built into primary care in a much more fundamental way.
Yeah, that's something that's incredibly interesting because I think many people have this take that in some cases our system is it's named incorrectly, that it's not really healthcare that we deliver, it's really sick care that we deliver. It's when someone's sick, then you treat them, right? As opposed to healthcare, where this idea of a little bit more holistic, where you do prevention as probably a huge part of the, the entire practice. So that's actually interesting that Tommy Douglas really thought about prevention was a key component of his comprehensive approach. Did he have I don't know if any of his writings or any of his later on in his life where he spoke more about that concept of what did he mean by prevention? Did he mean sort of incentivizing people to eat better, get better sleep, build better education system? Like, was it, what was his thought process, at least what was his ideal comprehensive healthcare system?
Well, it started with the sort of a comprehensive primary care clinic that would have nutritionists and others involved that would help people with that. But it extended beyond that to community groups that were prepared to offer exercise programs and other things that would, in a sense, address, you know, heart disease, diabetes, etc. And he would have, I mean, he would have argued that this needed to be organized. And in fact, Saskatchewan had a system of health regions, which he invested heavily in as through his government, in order to knit that together as a system. It was the first set of health regions in the country. By the 1960s, it had largely dissolved. And then it was recreated again in the 1990s in Canada. In Ontario, it took until the 2000s. But the point here is that there, it's not just a matter that you have the sort of the right organizations, but you need to knit this together into a system, a coherent system. But the primary care providers are critical because they, in a sense, need to be the people that uh, patients go back to all the time. That the emergency department should not be the main locus of your uh, either illness care or wellness for sure.
Absolutely. So thank you. I know we're right up against time. I don't want to take up more of your day because it is a Sunday for you, and I apologies for having to book you on a Sunday. But I very much appreciate your time. I will put, of course, in show notes where can people find some of your work. I know, of course, you're still contributing. I'm actually not contributing. You are a host at the Witness Yesterday podcast, which I will link below because it is a fantastic podcast. Everyone should really look for, actually listen to a lot of the interesting content that you have on there. Where else should people interact with you? I noticed you have a Twitter account or a quote unquote X account as
Yeah.
well. Go ahead.
Well, my X account's virtually inactive. Blue Sky would be a possibility. I occasionally do that. Also, um, there might be a couple other social media sites, but um, in terms of what I've written, ResearchGate is probably the very best source. LinkedIn is the other social media site that I'm beginning to use a bit more, but I'm not a huge social media guy, so I get on about once or twice a week.
It's probably,
But
honestly, it's probably a good thing that you don't use social media. I use it way too much, and I don't know what Tommy Douglas would say about that from my mental health perspective. But I think that's I will link all provide the links in the show notes below. Again, the most recent book that you published that we've talked about here is Tommy Douglas and the Quest for Medicare in Canada. Fantastic book. I'm going to get mine and have a read. I need to read it for sure. It's like I'm right now. I told you, Greg, beforehand that I'm waiting for it from the library. I'm like number 10 on a list of of people like that have actually want to read your book. And then the other component, maybe last but not least, besides this your book that people must read, Tommy Douglas and the Quest for Medicare in Canada. If people wanted to, what's a must read or must watch, must listen piece of content that you would say you would recommend people to go and read, watch, listen to about Tommy Douglas?
oh, wow. Um, that's a very good question. I think that, you talked about white mice, black mice, or white cats, black cats, etc. There was a, a short, and I think it's available on YouTube, definitely there, as well as on YouTube, there's his speech that he gave towards the end of his life that is phenomenal. Uh, he's very thin looking. He was already quite emaciated from cancer at the time, but he gave a speech that was absolutely incredible. So that's worth watching.
Thank you very
And
much, Greg.
but you
Or
know
go
what?
ahead.
There needs to be a film. There needs to be either a film or a television series about his life. And I'm going to approach a literary agent I know in Toronto, and I'm proposing this idea to him because I think it would make for one hell of a series.
That would be awesome. Of course, now round tripping this entire conversation, maybe you can get Justin Bieber to play Tommy Douglas in his early days or something. But thank you very much, Greg, for jumping on and having this conversation. Thank you, everyone, for listening. If you like conversations and content like this, please like and subscribe. Any questions, comments, please provide that in the comments below. And have a wonderful day. And thanks a lot, Greg, again for joining us. Thank you very much, everyone.
Real pleasure, Lester. Thank you.